Good morning, everyone. First of all, I must thank thank the organizers of this Iraqi Doctors Association for inviting me and giving me an opportunity to be the first speaker in the first conference. Thanks to Laith, thanks to Sam, and thanks to the whole Iraqi community. Just a few words about, I've been an emergency physician for 25 years. I've worked in about 4 different countries. And I've been told wherever I go, in every country you go, you will find an Indian doctor. I must say, after my observation, you don't find an Iraqi doctor in every country, but if you find them, don't lose them. They rock. And this is from first-hand experience. There are so many doctors in this room which I have worked in last 10, 15 years while I've been in Australia. And I must say, I must congratulate you guys, your hard work and the effort you put in your patients. I'll talk about my talk, but as I've been a passionate emergency physician for a very long time, and of lately, my passion grew into looking at that we are dumping a lot of emergencies in the hospital, where hospitals are getting overwhelmed. And with a group of emergency physicians from North Shore, we came up with this concept of walk-in emergency clinic to see that we can look after the 70% of the patients who actually don't need hospital. Can they be looked after somewhere else? So just a quick brief on that, and then we'll get going on the...
It's an emergency department, but not like you know it. No wait times, no triage system, just immediate specialist care.
It'll be a one-stop shop in terms of their assessment and treatment.
The new Wise Clinic at Macquarie Park is a walk-in centre with 15 senior emergency physicians plus a network of specialists on call. With 70% of patients who present at hospital emergency departments never getting admitted, this clinic caters to those with non-life-threatening conditions who still need urgent care.
Broken bones, kids with fevers or diarrhoea and vomiting, and patients with abdominal pain or chest pain.
Wise is equipped with blood testing, pathology, X-ray, dental X-ray, CT scan and ultrasound to avoid referrals, delays and to fast-track results.
Immediate access to those results when they come up, and that will allow us to therefore make good decisions early on appropriate treatment.
It came in handy last week for John Gill's daughter Ellie, struck down by a severe stomach bug. She was dehydrated from vomiting.
She was really sick. I was really concerned. I didn't want to go to a normal emergency where you have to wait possibly hours. I knew she needed treatment straight away.
When Jatinder presented in excruciating pain with chronic pancreatitis, he received express emergency care.
They did the blood tests. They immediately took me for a CT scan so that they could see what actually happened to the organ at that time.
Regardless of what you need once you're here, whether that be a blood test or a CT scan, you'll pay a single flat rate of $200 on the day, but that isn't covered by Medicare or private health funds.
I'm willing to pay more than that. I mean, you know, it's peace of mind.
Sophie Walsh, 9 News.
Thank you very much for giving patients a hearing to that. Look, this is facilities available. Please, there's a booth out there. If you want more information, please feel free to come and talk to me or Alison in there. Now, coming to diabetic emergencies. Now, diabetes is, Greeks have given us a lot in terms of our nomenclature of our medical terminology. So diabetes actually just means is passage of lot of something. And mellitus is actually the sweet honey we talk about. In our emergency career, we have always carried glucose under our pocket, and we always, any course you go to, any training session you go to, you're told A, B, C, do not forget glucose. And that's sort of a thing we say time and again, but still forget. Still don't do the basic glucose, which is just a tiny instrument available in every office, but it's such a rewarding thing to save a life who is going to die in a matter of minutes or times if we pick this up, especially in diabetics as well as non-diabetics as well. So we'll just go through a few areas which we'll cover here, which wanted to cover just a touch on. I'm sure then Dr. Abid, next speaker, would be giving in detail the diabetic pathophysiology, but I'll just touch briefly on that. And then I want to deal with 5 emergencies which we commonly deal: the diabetic ketoacidosis, hyperglycemic hyperosmolar state, hyperglycemic without obvious acidosis, and hypoglycemia, and some other associated emergencies which we'll just package in one slide. What is the role of a primary physician in a diabetic emergency? Prevention, the biggest one, and education to the patients so that we can actually prevent these episodes from happening. Regular monitoring of their diabetic condition, early identifications of their risk, and timely referral to the hospital care if required, and providing urgent care while you're waiting for a transport. I think these sort of fill up the broad way where we want to, the condition itself will be managed in an emergency department, but this is something which I think each of us as a doctor should be aware of what steps to do. And they're not rocket science. I don't want you to take too many messages from this talk. If you just take 2 or 3 big messages, that will be really helpful. Type 1 diabetes, I think this room is full of really smart doctors, and we know it's a condition where we are lacking insulin. And type 2 diabetes where insulin isn't working. And insulin has got 5 major functions which we should keep in mind while managing our acute situations in diabetic emergencies. It drives glucose into the cells. If it doesn't go into the cell for creating energy, it's going to cause hyperglycemia, and those effects are detrimental. And it drives potassium into the cell. That's something to remember. It can create problems if we don't keep that in mind. It's an anabolic and a glycogen storage hormone. It blocks fat breakdown and it blocks protein breakdown. Insulin deficiency leads to hyperglycemia, leads to ketoacidotic production because all the glucose is outside the cells are starving, and they start producing ketones, and hence we'll end up in acidosis. And hyperglycemia itself leads to osmotic diuresis and dehydration. 2 conditions, I'm going to take them together because for the sake of a primary health physician, we manage them pretty much similar in the first few minutes of these emergencies. Diabetic ketoacidosis, mostly hyperglycemic, but euglycemic. I will bring your attention to this, which we have recently started saying some adverse drug reactions have been notified, but I think we are seeing more than in emergency department than they are being reported. I'll talk, dedicated one slide to that. And hyperosmolar hyperglycemic state, which is a complication of a type 2 insulin, non-insulin dependent diabetes. If you put them together, diabetic ketoacidosis is a condition which is because of lack of insulin. Hyperosmolar is because of not being able to use insulin fully. How do they clinically differ? Majority of the hyperosmolar will have sugars more than 25 millimole, whereas diabetic ketoacidosis by definition should be above 11 to 15. pH is low, 7.3 in diabetic ketoacidosis. pH is always above 7.3 in the hyperosmolar. Bicarb has to be less than 15. In hyperosmolar, it is more than 15. Ketones are elevated in both, but very highly in high numbers in diabetic ketoacidosis because of your cells being starved. And in the hyperosmolar, they can be high, but usually less than 3. A pseudo-hyponatremia exists in the diabetic ketoacidosis. We have a calculation to find the corrected sodium, but not going into those details. And the hypernatremia is actually detrimental, and it is because of the hemoconcentration can be a complication and is got a big mortality to it. So these are the basic differences in these 2 types of diabetic emergencies, both related to hyperglycemia in most of them. And then we look into why these kind of situations happen. Insulin lack is the most common factor in Australia or in Western countries to be the cause of diabetic acidosis. Rest of the things can be common in both of the conditions. And as a part of our workup, we look into, once we have stabilized the patient, to find why this happened. And majority of the type 1 would be either non-compliant, or their pump is not working, or something like that. That's why they present to us in a ketotic phase. This is something which I've seen 8 patients of euglycemic ketoacidosis directly related to SGLT2 inhibitors, which is being used pretty commonly nowadays. It's a good drug, but like apixaban and NOACs came into the market, emergency physicians were the first one to bear the brunt of the bleeding of, though it has this side effect of this has been played down most of the time, but we have seen of lately last year 8 patients presenting to us with type 2 diabetics in ketoacidosis and on SGLT2 inhibitors. It tends to lower the insulin level, blunt the effect of the insulin level, while it's actually lowering the sugar levels. The sugar levels are normal, but the insulin effect is blunted, so the ketoacidosis kicks in. Simple approach to all these patients. I would, for a message to a primary physician, it's hydration, hydration, hydration. There have been a few guidelines being put out there saying give a subcut or a bolus dose of insulin before transferring to the hospital. Not a good idea, I will say, because what you'll end up doing is you give an insulin dose prior to sending them to hospital. If their potassium is normal, by the time you're going to reach hospital, they'll die of hypokalemia rather than diabetic ketoacidosis. So if a message has to be taken, IV line while you're waiting for an ambulance and a normal saline. Don't confuse yourself with too many solutions. Just normal saline, 20 mils per kilo, a bolus dose would save that life. If you have to give insulin, I would say it should be given in an emergency department once the electrolytes have been taken and a first gas has been taken. Investigating the cause and preventing complications we can look after in emergency department. So the principles of treatments are fluids. Fluids, keep it simple and stupid, 20 mils per kilo. Fluid bolus is the simple thing you can do to save that life at them. Insulin, when they reach the hospital, we tend not to give any boluses. We tend to start an infusion at 0.1 milligram per kilogram. And you want to keep the insulin levels in a way so that they can actually transport the glucose into the cell and save ketoacidosis. And acidosis, to prevent acidosis, you have to have insulin in the body, and if the glucose levels drop because you've given insulin, then you are struggling. You have to give dextrose along with the insulin at a separate infusion to keep the effect of ketogenesis away. Potassium is a big thing which even if the potassium is normal, we start the supplementation of potassium, because once the insulin starts going in, the shift of the potassium happens, and that can lead to various arrhythmias and various issues which are difficult to deal with. Other therapies, bicarb is discouraged as much as possible, antibiotics, monitoring sodium, magnesium, phosphorus, and in hyperosmolar, because they are very viscous, we tend to start some prophylaxis of heparin. Hyperglycemia without obvious acidosis can be there, and this is kind of a precursor of both these conditions. It's a thing which if we pick up early, we can prevent the happening of the two conditions. The biggest one, hypoglycemia, which kills people instantaneously and damages neuro, is something which has been advocated in all our ALS and ACLS courses. Do not ever forget glucose. But how do we manage that? We'll come to this slide in a minute. How do we manage that hypoglycemia? Management is pretty simple in simple words, but you have to consider two things. Is your patient conscious or unconscious? Is your patient diabetic or non-diabetic? Is your patient got an IV excess or doesn't have an IV excess? An ABCD standard approach to their airway, to their breathing, their circulation, and obviously you have taken a glucose, and the glucose is less than 2.6 as per definition, they are hypoglycemic. What do you give? Glucose, grab anything, a lolly, a chocolate, anything which you have around if they are conscious. If they are not conscious, make sure you have a hypoglycemia kit which has glucagon in it, and intramuscular glucagon gives a good response within a couple of minutes to anti the effect of the insulin. And how much glucose to do? If you're able to get a line in, the recommended dose is 50% glucose, 50 mils, which will give you 25 grams of glucose in the system. And if it's a child, in a child, the recommended dose is of 10% dextrose, it's 2 mils per kg. It used to be 10, they brought it down to 5, and then to 2 mils per kg. So these are the two sugars you will use intravenously. If you don't have an intravenous access, then glucagon is your friend, or a glucogel is also available, which you can just put under their tongue or rub it on their gums. These are the two things, if you want to keep in your practice, I will not discourage you from doing it, and can save some life. If someone has taken lots of sulfonylureas, then obviously this is a hospital medicine. We will use octreotide to block that effect as well. 5 other common medical emergencies which we see, which are actually red flags and associated with emergencies. Diabetics can have more cardiac events, diabetics can have more stroke events, sepsis, renal tract, vascular, diabetic, and perioperative complications. I think I'll make the best use of this time and conclude the talk here, and if any questions, please feel free to ask.
I personally worked for many years in emergency, about 16 years in emergency. I was senior person. But during the last few years, I worked for general practice. I found, I'm seeing the course shifting from the emergency to federal and federal, passing the ball to the state. How can we solve this problem? Because really needed for it.
I think these are politicians.
You need simple, you have the right to either all of them become federal or all of the state.
I know, this is a problem which we have been looking.
Really, it's a big problem.
Yes, I don't think we have an answer for that.
It's causing the patient, especially elderly patient. You send them a few times to do ECG somewhere, blood test somewhere, CT scan somewhere, X-ray somewhere, and this is also difficult for elderly.
Absolutely, our health system is very fragmented. I totally agree with you. Can't say. But do we have anything in our hands as physicians? I'm not sure.
Okay, any questions?
What is the most common presentation that comes with the diabetic ketoacidosis, like as a SNAP specialist?
Okay, so that's a very good question. I should have mentioned that the commonest presentation is they are altered level of consciousness.
So they come with like almost
confused, they could be confused, they could look like stroke, they could look like any syndrome. So you have to be just putting this as your differential diagnosis in every condition. That's why I say do not forget glucose in any condition you see. Walking in the emergency department, yeah. Anything else?
Any more questions?
Do you know?
I'll be making some comments about SGLT2 inhibitors and euglycemic DKA in my presentation. So,
awesome.
Yeah, there's one more question. We've got a couple of minutes now, I think.
One last question regarding the glucagon that you mentioned earlier. The kit itself, it doesn't have to have, you don't have to have an IV access, right?
You can give it intramuscular or subcut, either.
It will work within minutes, right?
Correct.
Sorry, because you said that you're going to discuss my question, your session, just because SGLT is one of the common medications. We use it in the GP set for the good control for the poor control diabetes.
I'm going to be explaining to you where they fit in and how beneficial they are, apart from glucose lowering. And but why don't I get started into? I'll get stuck into my presentation, and then I'll take some questions about SGLT2, and because it is a topical question, it's important. I agree with Dr. Arora. I think what was shown in the clinical trials was a very low rate, and it's still very uncommon. The benefits still outweigh the risks, but we are seeing probably more cases in real life because we're using the drugs so frequently, because they're such good drugs and they save lives. They don't just lower glucose. So we'll come back to your question. I won't forget you.
Thank you.
I'm pretty sure we'll keep using this drug, but just to be aware that that's not that uncommon is important.
Yeah, we always tell the patient that you have to drink a lot of fluids when you start this medication, just to avoid this issue. But if this is the only thing that we have to tell them, and there is more things we have to warn them, let us know. so to reduce the rate of
Thank you.
decay.
Thank you, Dr. Arora.